Good morning and welcome to the third lecture of neurology. And in this lecture, what we are going to discuss is the ascending and as well as the descending tract, or the motor system and the sensory system. As I told you guys, like though it's very important and it's very hard to like finish all the neuroanatomy in 2 or 3 lectures. Of course, no one can. But the thing is, just to make a lot of you understand what is the ascending tracts and what is the descending tracts. Um, the spinal, the central nervous system, or the nervous system, is divided into central nervous system as well as the peripheral nervous system. And in the central nervous system, it is the brain and the spinal cord, and peripheral nervous system is all the nerves which are carrying the sensations or either carrying the motor fibers. Now, the important part is that uh, what is the function of descending tracts? Of course, like these are the tracts which are originating from the brain or the cerebral cortex, and they are descending all the way through the spinal cord and going and supplying basically most of the motor function. Also, the autonomic nervous flow, nerve flow is also coming from the descending tracts, but I'm saying the motor flow because that is the most important thing you guys must know or to understand. So the tracks are named the names are very easy to remember. For example, if I will say corticospinal tract, what it means, it is starting from the cortex and going towards the spinal cord. Uh, there are many other tracks like reticulospinal, tectospinal, rubrospinal, vestibulospinal, and of course like the autonomic tract. And the thing is, they are traveling in the spinal cord, of course. So the function of all the, what you can say, tract is of course like all the impulses which start from the in the cortex, and they are traveling all the way down from the spinal cord to the peripheral muscles, for example. Okay, one thing which I was talking about is in localization, you can say, of the site of pathology. Okay, for example, there is something called as upper motor neuron lesion as well as lower motor neuron lesion. Okay, so what is that is, here we want a different type of slide, basically again this one. Okay, so what is upper motor neuron? uh, First of all, better to show you this thing. See, this one is coming from some part of the cerebral cortex, and this neuron is going all the way down in the spinal cord, and see, it is synapsing with some other neuron. So this one, which is inside the nervous system, the central nervous system, is called as the upper motor neuron. And this one, like after synapsing and it is coming out, the fibers are coming out, this is called as the lower motor neuron. It's written over here. Okay, upper motor neuron as well as the lower motor neuron. Same thing here. First order upper motor neuron, uh, like this one is like, of course, for the sensation, so that's why. Okay, this is the first order neuron, then there is a second order neuron, then there is a third order neuron. So these two neurons, which are inside the spinal cord as well as the cerebral cortex, they are called as the upper motor neurons, and this one is called as a lower motor neuron. Okay, so upper motor neurons They are found in the cerebral cortex, in the brain stem, okay, and they are simply carry the information to the lower motor neurons, which will go and innervate a muscle or anything, whatever the function is there. Okay. Now, why this thing is important in neurology? Why I'm talking a lot about this thing? Uh, because any patient who is presenting with some neurological features, okay, we divide them into two main categories. That is which one? Sorry. Uh, that is simply upper motor neuron as well as the lower motor neuron. Okay. So for example, this one is upper motor neuron. Okay. And this is lower motor neuron. Features, clinical features in neurological deficits. Okay, any patient, for example, what is stroke? Stroke is an example of like some part of the brain get run out of the blood supply and that's not functioning properly. So stroke is a type of what kind of lesion? It's something in the central nervous system, in the brain. So stroke is an example of what? Upper motor neuron type of lesion. Whereas someone, for example, in which his peripheral nerve is either cut or damaged, that is an example of what? That is an example of lower motor neuron type of lesion. Okay. So upper motor neuron type of lesion is also called as pyramidal insufficiency, but because of the pyramidal tract. Okay. But it's uh, simply easy to remember as upper motor neuron type of lesion. So upper motor neuron type of lesion is basically any lesion which is before anterior horn cell. In this case, this is the anterior horn cell. Okay. So any lesion before the anterior horn cell is called as upper motor neuron lesion. Any lesion which is before the anterior horn cell. So basically, what is anterior horn cell? It is a small collection of the gray matter in the spinal cord. Okay. And this one contains the motor neurons. What is the function of motor neuron? The one which will carry the signals to the motor part of the body, to the muscles for the movement. Okay. So I am talking about the descending tracts right now. Okay. So now any issue before the anterior horn cell, no matter either the pathology is in the spinal cord or in the brain, and in the case of cranial nerve, it is basically again any issue or any pathology before the motor nuclei of the cranial nerve. The cranial nerves, motor nuclei, are where? They are basically in the brain stem, most of them, either in the midbrain, either in the pons, either in the medulla. Okay, so in simple words, you can say upper motor neuron is upper motor neuron lesion, okay, or upper motor neuron lesion is basically anything which occurs in neural pathway before anterior horn cell. Okay, this is the main definition, you can say, of upper motor neuron type of lesion. Whereas lower motor neuron type of lesion, okay, lower motor neuron type of lesion is basically anything which occurs in the which nerve? Peripheral nerve, okay, or simply after the, what you can say, anterior horn cell, okay. So low motor neuron lesion is basically it affects the nerve fibers, okay, after anterior horn cell. Sorry, not after, either in or after anterior horn cell. Okay. Now, why I am stressing this thing too much? Because this one have a wide clinical application. Most of the things which are diagnosed are basically diagnosed based on these features. Just four things you have to remember. Okay, there are many things written in the books. Okay, maybe a lot of the presentations are written in the books, but you have to remember just four things. Okay. Number one, whenever anyone have upper motor neuron type of lesion in the body, that particular muscle group, when you will examine them, they will show spasticity. Now, I don't know how much you know about spasticity, but spasticity is simply increase in the tone of the muscles. Normally, our muscles in the body have some tone. When you're sitting and not doing anything, your muscles, your body is maintaining some tone. Okay. So when the tone of those muscles is increased, that is called as hypertonicity, or that is also called as spasticity. When the tone is decreased, that is called as flaccidity. Okay. So upper motor neuron type of lesion show what? Spasticity, whereas lower motor neuron type of lesion will show, sorry, will show what? Flaccidity, or you can say hypotonia. Now I'm not saying uh, flaccidity, because there can be hypotonia, the tone will be reduced, or atonia, the tone will be absent. Okay, this is the one thing. Second thing, in the upper motor neuron type of lesion will be what? That uh, there will be hyperreflexia. Like, whenever we check any patient neurologically, we check the reflexes. We tap the knees, or we tap the uh, ankle, or we tap the bicep tendon or tricep tendon, and there's a movement in the muscle. Okay, that is a reflex arc is there. So in these patients who have upper motor neuron type of lesion, they have increased exaggerated reflexes, whereas in lower motor neuron type of lesion, they have hyporeflexia. Their reflexes are weak, or there can be areflexia. The reflexes are absent. Okay. Third thing which you have to remember is what? That uh, in upper motor neuron type of lesion, spasticity is there, hyperflexia is there, and third thing is there is something called as Babinski sign. Babinski sign. What is that? That when we stroke the sole of the feet by a sharp object, starting from the sole and bringing it towards the little toe, okay, what happens that the uh, our toes, they go into plantar flexion, okay, and whenever there is upper motor neuron type of lesion, whenever we stroke these patients with, like for example, a patient of stroke, when you will stroke the bottom of like the sole of the feet with a sharp object and bring it towards the little toe, what you will find that their big toe will be extended or will go up towards the brain. This is the easiest way to remember. The problem is in the brain, so the toe will go towards the brain. This is called as planters are upgoing. This is also said as what? Planters are upgoing, or Babinski's sign is positive. Okay. So remember, when the toe is going towards brain, it means the problem is in the upper part, either spinal cord or either brain, or in the central nervous system or upper motor neuron type of lesion. Okay. So it is abnormal, of course. It is abnormal response because normally the toe goes into plantar flexion, not upwards. That is Babinski's sign is negative. So in these patients, the Babinski sign will be positive. Okay. So there will be dorsiflexion of big toe, and all the little toes will be go in abduction, will be separated from each other. Babinski sign is positive. But whenever you will do the like whenever you will check someone who have a lower neuron type of lesion, their Babinski sign will be negative. Or the other way to say this thing is what? Planters will be down going. Planters will be down going. Okay. One more thing uh, is when we observe, when we see very closely, we inspect the muscle group, the involved muscle groups in lower motor neuron type of lesion, you will find the muscles are twitching. Okay. These are small group of muscles which are contracting and relaxing. Okay. And this can be easily visible by the naked eye. Okay. So that is called as fasciculations. Fasciculations is only present in lower motor neuron type of lesion. Fasciculations will be absent in this one. Okay. Fasciculations absent in this one. Okay. The strength of the muscles, the muscle weakness will be absent in both of them, but one will give a pyramidal type of weakness and the other one will give paralysis. But these are the four most important things, guys, you have to remember. And these are the basis of the diagnosis of all the, what you can say, either the patient has something in the CNS or in the PNS. Okay. So, very important thing to understand, like before going into detail of all the other things. So anyone who is showing these features on examination, it is upper motor neuron type of lesion. Anyone who is showing these features, this is lower motor neuron type of lesion. There are certain conditions which give mixed pictures, both upper as well as lower motor neuron type of lesion. There are certain conditions which are there, but of course, like we are going to discuss them later when we will start the clinical medicine. So okay, guys, as I told you that there are a lot of, what you can say, uh, uh, descending tracks. Okay, because right now we are studying the motor system. When we will study the sensory system, we will study the ascending tracks. Okay, so now when we are studying the descending tracks, guys, I will explain that thing here. See, the components is upper motor neuron, which is the pyramidal system, lower motor neuron, extrapyramidal system, and cerebellum system. And what are the functions of these voluntary movements and coordinate movements? So, what is pyramidal and what is extrapyramidal tract? Basically, two tracts. One is called as corticobulbar, one is called as corticospinal. These are the two major tracts which start from the brain, you can say, and run downwards towards the body, and they are related with the motor movement. Okay, so uh, now basically corticobulbar, as you can see, like what is corticobulbar? Starting from the cortex bulbar and finishing in the brainstem, whereas corticospinal is starting from the cortex and going spinal, corticospinal, going all the way to the spinal cord. Basically, these two tracks are involved in controlling all the motor function of the body. Okay, so why corticobulbar tract I'm talking about here? Because corticobulbar is the main tract which is starting from the cortex and ending up in the brainstem, because over there it is connected with different cranial nerves. For example, facial nerve, which is a motor nerve, so it carries the fibers for the facial nerve. Corticospinal, why it goes all the way down to the spine? Because that one is controlling basically all the muscles of the body by which we are moving. Okay, so all the muscles on the face, muscles of mastication, muscles of facial expression, they are present in corticobulbar tract. Bulbar means what? Brainstem. And what is corticospinal? All the other fibers which are controlling the rest of the movement, they are in corticospinal tract. Okay, corticospinal tract, I will not discuss here corticobulbar tract, rather I will discuss corticospinal tract. Okay, mostly. So why we call it as pyramidal tract? Simply because when they pass through the medulla oblongata, it make pyramid. Okay, and that's the only reason. Because when you will, if you will open your atlas, or if you have seen the brain anatomy in reality on cadavers, you will examine the medulla and you will found that in the medulla this tract is running and they appear like pyramids, and that's the only reason they are called as pyramidal tracts. Okay, so this is the thing. Now the important thing to mention here is all these tracts, they start into the motor cortex here. This is the brain, this is the frontal lobe, parietal lobe, occipital lobe, temporal lobe, and these are the areas, the important areas they have written. So the one which is in front of the precentral gyrus, this is the precentral gyrus. This here, all the motor, what you can say, centers are located, and after precentral gyrus, all the sensory areas are there. See, taste, speech, here, speech, but like by which we are articulating and all this stuff. And how the body is representing, this is like they're showing you the brain from one side, okay? But if you are going to make a section from here, this red line, okay, and look at after cutting from here, you will found a picture like this. See, now you will see here how the body is represented. Basically, most of the area, see, you can say from here to here is the face area. Then a bigger area, you can say from here until here, is taken by our hands. And then very small area is dedicated to the lower limbs. Now see, you can speak, you can make expressions, and you need fine movements when you're speaking. So simply, you need very much type of uh, fine movements and expertise to to speak, to make expressions. So that's why the brain have a big area for our face. And then we have to do, for example, handwriting needs some fine movement, so a big area is given to the hands, whereas with legs, we don't do such fine movements, rather we walk or we run or we kick. Okay, simply like I'm just giving you an example that not much fine movements are needed, so that's why a little area is given to the leg area. By the way, brain have a thing called as plasticity. It comes from the word plastic. What is plastic? Like we can mold the plastic into anything. For example, the people who lose their hand, or even like someone who have hands, if from today you will start writing from your feet Of course, your handwriting will be very bad, but after some time, your foot writing, sorry, will become better, and there will be one day that, have you seen the people who can draw from their feet, who can do a lot of stuff from their feet? Why? Because this area will become bigger and bigger. More and more neuronal connections will be there. Okay, so this is called as homunculus presentation of the human body. Okay, see this one, homunculus. This is the primary motor cortex. Okay, so the fibers are arising from here. For example, the muscle which is controlling your thumb is arising from here, making a lot of connections, and the fibers are ultimately going to your thumb. Okay, okay, this is the tract which I wanted to explain you. Okay, here what I am showing you is corticospinal tract, not corticobulbar tract, because corticobulbar tract, it ends up here in the brainstem, because here there are all motor nuclei for our cranial nerves, right? So the nerve fibers for the corticospinal tract, they arises from, these cells are called as pyramidal cells in cerebral cortex. And if I'll discuss more about the motor area, basically there is a primary motor cortex and then there is a supplementary motor cortex over here. So most of the fibers for this tract, they arise from these supplementary and primary motor cortex. Okay, and then they go down through the cerebral cortex. Okay, and they pass through the pyramids of medulla oblongata. Okay, they pass all the way down you can see over here. Okay, and now they make two tracts. One is called as anterior corticospinal tract and one is called as lateral corticospinal tract. What you can see over here is that the fibers which are making anterior corticospinal tracts, they are staying on the same side. See, this is the half of the body. Whereas the fibers for lateral corticospinal tract, they are crossing over. Okay, one of the word which you see in the medical books for this crossing over is called as decussation. Okay, so decussation is simply crossing over. Okay, so these fibers, they will decussate or cross over onto the other side, forming what? Lateral spinal corticospinal tract. So this one is anterior corticospinal tract, this one is lateral corticospinal tract. Okay, so most of the fibers, okay, most of the fibers, around 80%, they cross over, they make lateral corticospinal tract. Less of the fibers, they go down on the same side, and before leaving the spinal cord, they cross over. Now listen carefully, both of them, they have to cross over. Okay, guys, but the lateral corticospinal tract fibers, they decussate or they cross over in medulla, whereas the 20% of the fibers, they keep on running down until they have to leave from the body at C3 level, at T12 level, at L2 level, or whatever level is there. They run all the way down through the spinal cord. So simply, anterior corticospinal tract is a small tract and lateral corticospinal tract is have most of the fibers, 20% of the fibers run in anterior, by the way, less than 20, and you can say more than 80% for fibers, they run in lateral corticospinal tract. Okay, so this anterior corticospinal tract, okay, the fibers, they are coming from the, of course, the cerebral cortex. Okay, but remember guys that they do cross over to the opposite side just before leaving the spinal cord. Okay, whereas the lateral corticospinal tract, they decussate or they cross over at the level of medulla. Okay. Rest is same. The function is more or less same. Basically, lateral corticospinal tracts, it control fine movements. Okay. And what you can say, like our hands or our feet, okay, which need some fine movements, you can say. Those fibers are in the lateral corticospinal tract. Anterior corticospinal tract basically have the fibers which control our axial muscles, the muscles in the back, you can say, around the vertebral column. So, which are not too much involved in fine movements. Of course, you don't do anything from your back muscles. Okay. So, this is the introduction for this one. So, these are called as pyramidal tract. Okay. Now, what is the function of pyramidal tract? Simply that it controls the voluntary muscle movement, okay, which you are doing yourself. Okay, so corticospinal tract control the muscles of the body. Corticobulbar tract control the muscles of face, or you can say head, swallowing, phonation, tongue movements, all the muscles. Okay, so this thing is important. Okay, now this system is called as pyramidal system. Now there is one more thing that is called as extrapyramidal system. So extrapyramidal system basically control the involuntary movements. Okay, they control the involuntary movements. So they for example, like they are the one which maintain the muscle tones where that is important. Okay, so all the rest of the tracks simply, they are called as extrapyramidal system. Whatever I name in the start, like rubrospinal, reticulospinal, uh, vestibulospinal, or tectospinal, whatever, like all they are the part of what you can say extrapyramidal system. Okay, so guys, like I hope you understand this thing. Neurology is okay. Now, whenever there is first order neuron is damaged here, or this one, it will give what kind of clinical features? Upper motor neuron type. Whenever anything will happen in the anterior horn cell or later, lower motor neuron type of cells. Okay, so for example, if there is like this fibers, like there is an infarction over here or there is a cut over here, what will happen? That the patient will present with spasticity in that muscles, hyperreflexia in that muscle group, as well as Babinski signs will be positive. Whenever the problem is somewhere here or later, they will present with fasciculations, they will present with hypotonia or atonia, hyperreflexia or areflexia, and Babinski sign will be negative, right? So this thing is important thing to understand. I hope you understand this thing. So this one is like they are showing the ascending tract. Of course, when we'll study the sensory system, I'm going to discuss this thing. So again, like guys, whatever I explain, this is further explanation of that. This is like the pyramidal system. I already told you. I did not show you this thing before because that photograph was more clearer. Of course, like they are talking about the same thing. I'm just scrolling down just so that if you get any new information, okay, you can discuss. You can read about that. Okay. Corticobulbar, as I told you already. Okay. Okay. Now, what will happen when any descending tract will be damaged? What is the cause of damage? Of course, when we'll study stroke, when we'll study these things, of course, we'll discuss that. See, I told you about lower motor neuron type of lesion. What things they will give? Same things are written. There will be nothing new. Okay. For example, anterior root or plexus or peripheral nerve or spinal cell, anterior horn cell has gone. It will give you lower, and how they present, like again the same thing will be there. Okay, You will find many terms like this. What is plegia? What is paresis? Okay, you are going to find a lot of these words again and again. So what is plegia is simply paralysis. What is paresis? Okay, it is basically uh, weakness. Okay, so whenever there is plegia, it means it is paralyzed completely. Whenever there is, for example, monoplegia or monoparesis, okay, so monoplegia means what? uh, like one part, one limb is paralyzed, and there is monoparesis, it is like weakened movement, right? Or one arm or one leg is involved. Hemi means half. Crossed hemiplegia, okay, like of course I'm not going to these things right now. Why? Because I will tell you in a while. Para means what? Both the lower limbs. Quadri means all four limbs. And when we will uh, substitute these things with paresis, of course, that means weakness. Okay. Uh, okay. Now we will extrapyramidal system. They talk about the same. Here, three things are written. What is cerebrospinal? What is vestibulospinal? What is reticulospinal? Okay. Now one more thing, guys. There are basal ganglias. Okay. Now, basically, I usually explain basal ganglia when I start what you can say Parkinsonism. I started talking about them at that time. But basal ganglias are basically, they're also called as basal nuclei because they are a group of nuclei which are present in the cortex. Okay, uh, like in our basal ganglia, there are different structures called as the putamen and quadrate nucleus and globus pallidus and substantia nigra and so on and so forth. Okay, what is the main function of what you can say all these basal ganglia all together? I'm just talking about one function. Okay, or the most easiest way to tell you, uh, like simply, basal ganglia are controlling or fine tuning, you can say. They are fine tuning the muscle movements. Okay, so whenever there is any basal ganglia problem in human beings, what happened is like either there is some hypokinetic type of disorders or hyperkinetic disorders. Simply, they like whenever basal ganglia are damaged, there are movement disorders. For example, the person may have tremors, the person may have athetosis, the person may have hemibilismus. What I'm saying, you can see the videos on YouTube, like how this abnormal movements looks like. Okay, athetosis, hemibilismus, chorea, okay, and all these things. So whenever basal ganglia are damaged, people have what? Movement disorders. Okay. So now, of course, like these are all the what you can say uh, components of the basal ganglia. Okay, corpus striatum and all this stuff. Okay, so see, like there is a huge connection. Like there is a direct pathway and indirect pathway, excitatory or inhibitory pathway. Cerebral cortex, it it gives the impulse. The impulse go to putamen, and see, it is inhibiting globus pallidus. It is inhibiting output nuclei. This one is activating. Red is excitatory. This one is activating subthalamic nuclei, which is activating occiput. So, like, I will suggest you before reaching to the topic of Parkinsonism, at least watch one lecture of basal ganglia. Okay. Now, okay, I will tell you one thing, one concept I think which we should start making from now. What will happen, guys? For example, someone have a pathology over here, stroke. So if the stroke, for example, is in this area, so of course the hands will not work. Okay, but which side of the hand? For example, the right side of the brain is gone. So these fibers are crossing over and supplying the hands on the left side. So when there is stroke on the right side of the cerebral cortex, the muscles will stop functioning on the left side. Very important to understand, to remember. Whenever there is pathology in the midbrain, for example, on the right side, the muscles will stop working on the left side. For example, when someone have a pathology on the right side of the spinal cord at this level, now see, most of the fibers which will be gone is the anterior spinothalamic tract, sorry, corticospinal tract. But these fibers are safe. Why? Because this one is crossing over. So whenever there is pathology on this side of spinal cord, the motor function will be fine on this side, but the motor function will be gone on this side. Why? Because remember, guys, the fibers which are controlling our right side of the body are coming from this side, but at the same side, like on the same side, on the other side there is more fibers which are coming and which are crossing over on the other side. So right side of the brain is controlling the muscle on the left side, whereas the left side of the brain is controlling the muscle on the right side. But when we are talking on this level, and there is hemisection of the spinal cord, hemisection, half of the spinal cord is gone, then the fibers which are coming from the right side, they will be protected because they decussate or cross over at like at medullary level, but the fibers will be destroyed on this side, which are coming from the left side of the body and which have crossed over in the medulla. What I mean to say is, if I will draw one track like all the way going over here and the fibers are crossing over here, so if the spinal cord is damaged over here, so of course the fibers which are coming from the left side of the brain will be damaged here, and there will be weakness on this side of the body. Okay, so this is very important to understand, guys, because this is something which we do in localization of the pathology, like either it's in the cerebral cortex, either it's spinal cord, or what. Now see, someone have a stroke over this part of the brain. For example, the fibers which are controlling the upper limb, they are gone, so they can present in what? Left-sided monoplegia or monoparalysis or monoparesis. Okay. For example, someone who have a big infarct, which is damaging all the upper limb and lower limb fibers, they will be having hemiplegia. For example, someone have a big infarct affecting all this part, having what? Hemiplegia. All the face of left side, all the arms of left side, all the legs of the left side will be not working. Someone who have a transaction of the spinal cord at this level, the spinal cord, for example, someone have a gunshot, someone have a stab wound, and their spinal cord get cut at this level, what will happen? That, for example, this is a level T10. Okay, so what will happen? Like all the fibers which are below T10 will be damaged, destroyed. So they will present with something called as paraplegia, okay, or paraparesis. Why? Because now both the lower limbs are not functioning fine. Okay, so there is first order neuron, there is second order neuron, there is third order neuron. What is first order neuron? First order neurons basically conduct the impulses uh, uh, from the you can say precentral gyrus, okay, and then they pass through the internal capsule here. Internal is called as the internal capsule. I don't know how much you like, you know the names of the brain parts, okay, and then they pass through the thalamus, caudate nucleus, and they go down, and they, what you can say, they pass through the midbrain, pons, and medulla, and then they continue downwards. Okay. So some of the time, for example, if there is this first order neuron can be make a connection with the second order neuron over here. Okay. So for example, a first order neuron can end up in the brainstem and synapse with a second order neuron. Okay. So, or maybe it lies like this, that the first order neuron is going all the way down below and then synapsing with the second order neuron. Okay. And if there is second order neuron, so of course, like for example, in medulla oblongata, if there is a second order neuron, of course, they enter the spinal cord and they synapse with the third order neuron. Okay. So simply how many connections are there? We name it as first order neuron, second order neuron, and third order neuron. Okay, so it's like this one, this is the first order neuron, this is the second order neuron. See, it is making connection with the third order neuron, second order neuron, first order neuron. Okay, or in that this case, first order neuron, second order neuron, and third order neuron. This is what they are showing as thalamus. Okay, they are making connection with the thalamus. So if you guys understand this part, guys, then what you can say, we have done this thing. Okay, we can go on to the sensory system, by the way. Okay, wait. These are the names of some involuntary movements. Okay. Oh, by the way, just 14 minutes is left, in 1 hour. So it's better to explain you what is reflexes and what is deep reflexes, what is superficial reflexes. Okay. And then we can discuss what you can say, some other things, and then we will go on discussing the sensory system in the next part. Okay. Wait. Okay. See, there are different type of reflexes. One is called as corneal reflex. If you will touch cornea, what happens? Your eyes blink. Okay. Pharyngeal reflex. There is bicep reflex. When you will hit the bicep tendon, your bicep muscles contract. When you hit the tricep tendon, your tricep muscles contract. When you same like this, whatever you are hitting, you are getting some response. Here they are showing a very simple type of representation. See, you are hitting with the hammer the tendon of corticeps, and what happens, like the sensory neuron is taking the information to the dorsal root of the spinal cord, enter, and there is an interneuron which is connecting the sensory neuron with the motor neuron. This is called as the interneuron, and this one is taking the sensation over here that there is a stretch. So basically, when we hit with the hammer the tendon, we are giving them a stretching stimulus, which is carried by a sensory neuron, and there is an interneuron between these two, which gives the motor response, and what will happen, that the muscles will contract. This is a very easy representation of a superficial reflex. 5 steps in a neural. See, step 1, activation of stimulus and activation of receptor. Step 2 is activation of the sensory neuron. Step 3 is information processing in CNS by the help of interneuron. Step 4 is activation of the motor neuron, and step 5 is like we get that response. Again, like this is what you can say a monosynaptic reflex. If you will touch a hot thing, impulses are taken from the posterior root horn, and there's an interneuron, and then the efferent neurons are coming, and you are going to withdraw that. Again, showing the same hammer. So what kind of reflexes are there? There is deep reflexes, there is superficial reflexes, as well as there are pathological reflexes. So pathological reflexes, of course, like which are not there normally, but they show some sort of, what you can say, abnormality simply. Okay. Now, Deep reflexes, weakness or disappear. Lower motor lesion and reflex pathway increase the sign of upper. I explained this thing before, right? Like what will happen in lower motor neuron, what will happen in upper motor neuron. Superficial reflexes, again, that disappear or weaken in upper or motor neuron type of lesion reflex pathway. Coma, anesthesia, sleep, or old people. Okay. So, what you can say simply, most of the time, we check the deep reflexes in the human body. Okay. For example, we check the bicep, we check the tricep, we check the patellar, we check the ankle. Okay. They are also called as tendon reflexes simply. Okay. To check the cranial nerves, we can check, for example, the corneal reflex. We can check the pupillary light reflex. We throw the light in the pupil and it constricts. There is vestibulo-ocular reflex as well. There is jaw jerk reflex as well. Even gag is a reflex. You put your finger inside your mouth and you gag. That is a reflex, right? In pediatrics, we also check some reflexes. For example, sucking reflex, rooting reflex, Moro reflex. Just to check the neurological system, either they are present or not. So, abdominal reflex, for example, is a type of superficial reflex. Okay. What is done is like we stroke the abdomen around the umbilicus. Okay. And we see the contraction. Okay. The 7th and the 12th segments of the thoracic vertebra, they are the ones which are involved. Okay. So, for example, when the abdominal reflex is absent, okay, of course, like it is normal, okay, but in many times, it is absent due to some conditions. For example, Brown-Sequard syndrome. I will explain you that thing in a while. What is that? Okay, so we check that. Okay, now before going to further detail, okay, like I wanted to teach you in this lecture what you can say a lot of you can say syndromes like Medullary syndrome or Wallenberg syndrome. Okay, but I think like better to go through the sensory system first, and then like you will be having better understanding of these syndromes. Okay, so midbrain, what is that there, and yes, very very important. Yes, in this lecture we can discuss what is cerebellum. Now cerebellum is, as you know, like it is a part of the brain which is located posteriorly, right? And cerebellum is very interesting part, by the way, guys, because it gives some wide representation in the body. For example, dysdiadochokinesia. When I will teach you this thing in detail, of course, like I'm going to talk about that in detail. Cerebellum. First of all, one thing I want to make clear about cerebellum: the fibers which are coming from the cerebellum, they don't cross over. So the right side of the cerebellum controls the right side of the body. The left side of the cerebellum controls the left side of the body. Okay. So cerebellum is doing a lot of functions in the body. Okay. A very important function. C for cerebellum. Remember C for coordination. It coordinates different movements in the bodies. You can see. Okay. The best function you can say you want to remember about cerebellum is it is a center of coordination. Okay. Without this, the coordination in the body is gone, and the movements are not like in the healthy person. For example, the patients who have cerebellum, they cannot walk properly. They cannot do the fine movements properly. They have tremors. Okay, and which we do something called as finger nose test. Okay, I don't know how many of you have seen the video or not, but finger nose test, one of the things which we do, like they pass point the things and all the stuff, and they have nystagmus in the eyes, and many other things occur in the patients. So they maintain muscle tone and equilibrium. They are the one by which we are doing fine movement and we are maintaining our balance. Okay, so of course, like the fibers which are coming from the right side of the cerebellum control the right side of the body. The fibers which are coming from the left side of the cerebellum control the left side of the body, and the fibers which are coming from the center of the cerebellum basically controlling the central muscles or the axial muscles of the body, the muscles which are around the vertebral column. So the story is simple. Now here is the vertebral column. There are 33 vertebrae. By the way, when I teach in the class, I always ask how many vertebrae are there, and I found like many people they don't remember. 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal, and sacrum and coccygeal they are fused together. Like these 5 are fused together, and these fibers and these five are fused together. And basically, how we number the spinal nerves or the nerve roots is, by the way, from where they are coming out. See C1 and C2, C3, 4, C5. Remember, there like the C1, like there is 7 cervical vertebra, but there are 8 cervical nerves: C1, C2, C3, C4, C5, C6, C7, C8, and thoracic vertebra are 12. So there are 12. Lumbar vertebra are 5. So there are 5. Okay, so it goes like this way. So you can see over here, right? S4, S5. So based on from where they are coming out, okay. Just remember C, cervical have the 8, and then there is, depending on the vertebra, from where they're coming out, we name it according to that. So the point where spinal cord tapers off, it is called as conus medullaris. Okay, and then there is a small thing coming down and just touching over here called as phylum terminale. Okay, so this area is called as quad equina. Basically, this is the area where the spinal cord is not there, but a lot of nerve fibers are running, right? This is called as what? Quad equina. So this is a distal end, you can say. You can see over here. This is conus medullaris, where the spinal cord is ending. All the nerve roots are coming down. This is called as quad equina. Okay, and this is called as phylum terminale. Thin thread of fibrous tissue at the end of conus medullaris. This is phylum terminale. So this is like the real picture. So 31 spinal cord segments are there. Cervical spinal nerves, thoracic spinal nerves, lumbar nerves, and sacral nerves. So, of course, like spinal cord is an extension of the brain, contains white matter, which is the nerve tracts, and gray matter, which are the cell bodies. It is covered with meninges. Same thing, subarachnoid, pia or pia matter, and what you can say, dura matter. CSF is running in that. Spinal cord is very important. Why? Because all the descending and ascending tracts are over there. Okay, and the cord actually extends from vertebral C1 to L1, of course. After that, that's why when we want to do lumbar puncture, we want to put the needle inside the spinal cord. Inside this, to take out the CSF, to reach the CSF. We do it below L2 level, because above that, of course, we don't want to damage spinal cord. End of the cord terminus, conus medullaris and thoracic nerve begin to elongate, and lumbar and sacral nerves with very long roots which bundle together to form equina, quad equina, which is horsetails. Spinal cord level and corresponding vertebral body. Upper cervical, same as cord level. Lower cervical, 1 level higher. Upper thoracic, 2 level higher. Lower thoracic, 2 to 3 level higher. Lumbars is T10 to T12, and sacral is T12 to L1. So Now, when you do the cross section of the spinal cord, you will find the dorsal posterior horns and anterior horns. Posterior one have sensory cell bodies, and anterior one is motor cell bodies. Okay, you can see over here. So this is the posterior horn. This is the anterior horn. All the sensory cell bodies are over here. All the motor cell bodies are over here, and different tracts are running over here. See, ventral spinothalamic, lateral spinothalamic. Ventral means anterior, of course. Okay. Uh, Ventral spinocerebellar, dorsal spinocerebellar. This is the dorsal root from where the sensory input comes, and this one is like the motor one. From the motor input, output goes out. This one is the posterior columns or fasciculus cuneatus and gracilis, and this is the lateral corticospinal tract and tectospinal, ventral reticulospinal, and vestibulospinal, and all this one. Okay, so this thing. So now, simply, that's the end of the lecture, guys. In the next lecture, we are going to talk about the sensory nervous system. Then we will start talking about the condition simply. Thank you.